So let's jump into this case a little bit. Like I said, about a year and a half ago, it was just right in the middle of all the first year of COVID. I had a patient give me a call. I'd been seeing her for a number of years, and she called me up and she said, you know, my son was just released from prison. He's been there serving a 3-year sentence for drug violations. And he's clean now. He wants to straighten up his life. He wants to get back into society, but his teeth don't look very good. And he's worried that he's not going to be able to find anybody that'll talk to him about employment because his teeth don't look good. And so I said, well, yeah, let's take a look. Let's bring him in and see what he's got. So he showed up, and he was 31 years old, and that was his main complaint, that his teeth were ugly. But he did complain that they were uncomfortable too, that they hurt him some. He did report the history of tobacco and meth use. He also told me that he'd just gotten out of prison. He also said that while he was in prison, just about 3 weeks before he was released, he had had a tooth extracted. But they wouldn't do anything for his ugly teeth. All they would do is extract the tooth. So that was happened, and obviously, or not necessarily obviously, but he didn't have a lot of financial resources, having had been in prison for a little while, and so his mother wanted to help him out, but she had some limited resources as well. But she wanted to do what she could to fix his teeth so that he could look better and hopefully get a job. So when he arrived, I looked in his mouth, and that's what I saw. And I agreed, they were ugly. So we took some pictures of it. And here's some kind of close-up of the two sides. It's a little blurry when it's that big. Anyway, we decided, well, let's take a good look, and so we did a full exam on him. We looked at all of his teeth, and we took some radiographs and created a treatment plan for him. These are the radiographs we took of the lower anteriors, and obviously I was a little concerned that we might have some pulpal involvement, and this central incisor over here I was especially worried about because the PDL was a little widened, but it was asymptomatic, and we didn't have really any exposure of it, so we decided to go ahead and restore it so that we could hopefully take care of it without any pulpal concerns. These were his posterior radiographs. You can see number 19 had just been recently extracted. That's the one they did in prison. And number 2 is pretty broken down and really not restorable. Here's a radiograph of number 2. So after we had gotten all of our data together, we tried to decide, well, what are our treatment goals for this patient? So we decided we wanted to obviously address the pain and infection, and we wanted to deal with that first. And then we wanted to stabilize things. I like to use the term, we want to put out the fires. We can't rebuild something while it's still on fire. So we wanted to do that. Then the next thing we wanted to do is kind of fix things up so that he was functional. And then finally, we wanted to rebuild and strengthen the dentition. And I thought it was kind of interesting that here at the dental school, we teach the students to kind of treatment plan their cases in this order, to take care of the urgent things, the caries control, and then the restorative and definitive work. And so that's what we wanted to do for this patient. So we went ahead with this treatment plan for the posterior, and I'm not going to spend a lot of time on the posterior because what I really wanted to show you and talk about was what we did in the anterior. But you can see we did a lot of work in the posterior too. We started out with some SRP and prophylaxis, cleaned things up for him, and then we took out that root tip on number 2. And then we did quite a few composite restorations. None of them were extremely deep or any real problem other than just that they were carious. And so we took care of that, did a lot of work. We did that in a couple of visits. We did a right side visit and a left side visit to take care of those for him. We decided that with the missing tooth for number 19 that he would like to do an implant there. So it was healing fine and there was no infection or anything real urgent there. So we decided we'll push that out to the definitive phase of his work. So we've got the caries control taken care of in the posterior. Then we had to decide what are we going to do with these anteriors. There was a lot of things that went through my mind. Well, what do we do for this? Because we want to get him so he can go get that job. So we said, well, what are our options? We could do build-ups and full coverage crowns on these. Finances were a little bit of an issue, and so that made this option a little more difficult. It takes time to do all these build-ups and preparations and lab work and everything, and he wanted to go get a job yesterday. So that was kind of a concern as well. And if you remember from the pictures, there really wasn't very much tooth structure left on some of these teeth, and so we were concerned about retention and about strength, and you all know the size of these lower anteriors are really small, and by the time we cleaned out the caries, we were worried that there was not going to be much left to support a fixed prosthesis. And those of you who've worked on lower anteriors for crown preps, you know they're difficult. And a lot of times there's not a whole lot left of those teeth. Dr. Taylor's nodding his head. So that was one of our options anyway. We thought about extracting all those in the anterior that were broken down and replacing them. We thought about implants there. Again, there was concerns and problems with that. It's costly and time-consuming to do that while we wait for implants to heal and things. We considered a removable partial denture, and that would have been a viable option. We could have replaced number 19 in the process of doing that as well. But the patient flat out said, I don't want anything I can take in and out. And I know a lot of you have probably made a lot of partials that unfortunately sit in the dresser drawer and don't get worn. And so with him flat out saying that he wouldn't wear it, I was a little hesitant to go that route. We wondered about doing fixed bridges, maybe a fixed bridge from canine to canine. But again, cost and time and things, that didn't seem like a real attractive option. So we went to our next option, and that was to place direct composite restorations. And after we consulted with the patient about this, we decided we'd try that and see how we did. So we got him back for an appointment to do that, and the considerations we were worried about here was obviously the pain and discomfort and pulpal involvement because they were really broken down. But surprisingly, there was none. We wanted to put out these fires so they didn't get any worse. And we left the door open to do more definitive kind of work in the future. Whether we do any crown and bridge on them after that, or whether we end up losing any and doing implants or whatever we might decide to do. So this was kind of our treatment plan and our goal initially, and we'll see how it goes. All right. So again, we just decided to go with this option. So we got him in and isolated the teeth and removed all the caries in the anteriors. And I wish I had taken some progress pictures along the way. I just took some before and after pictures, but wanted to show you what we ended up with. This was the lower right side, and this was taken immediately after it was placed, but it made quite a difference in how they look. And here's the left side after it was all done. And I'm not quite sure how number 23 survived, because I don't know if you remember the before picture, but number 23 was unaffected by all this, but the rest of them weren't. So here's our kind of before and after, so you can see what we did there. We basically just removed all the caries and isolated these teeth and restored them with a direct composite restoration. We used, I tried several different shades and several different composites to see what might look the best and match the best, and it was interesting that I actually ended up using this Omnichroma composite. I don't know if any of you have ever used that, but it basically just comes in one shade, and it somehow takes on the shade of the surrounding structure pretty well. So that's what we used here, and we used the Peak Universal Bond to bond it on with. So here's our finished result. You can see the before and the after. He was thrilled, and I haven't heard if he got a job yet or not. As unfortunately happens, sometimes you work on these people and they don't come back. So I haven't seen him yet since we did this, and like I said, it was about 1.5 years ago. But I'm hopeful that he did find a job and that these are holding up well. I'd like to see him again and take some pictures of what they look like 1.5 years later. But generally, they turned out pretty nice, and he was very happy. He stood up with tears in his eyes and gave me a big hug and thanked me for doing this for him. So that's basically this case. We go here. Any questions? Yeah.
I feel like we see stuff like that all the time with patients that want to make a big aesthetic change with very limited resources. So as far as like coding, things like this, is this just like a 5-surface filling, basically?
Yeah, that's how I coded it. It was a 5-surface direct restoration on those. It was what, 2335, I think, is the code on it. Yeah, and you could maybe bill it out as a build-up or something if you were intending to do, crowns over it later. But we use that 5-surface code. Yes.
You may have said, and if I missed it, I'm sorry.
Hold on,
Did
Barbara.
you? If you said, I'm sorry I missed it, did you do all 4 incisors at one visit, or lower left and lower right?
Yeah, we did them all in one visit. We just did all of those right up front in one visit. Yeah. Yeah.
I think it's amazing to me what the material scientists have given us to be able to use for materials, and composites have come a long ways, and they're not, how long, we don't know how long will anything last in a given mouth, but what a great service. I saw this case actually it was probably about 1 year ago that Dr. Dickson had done, and I had him present this to the fixed prosthodontic course because I wanted the students to kind of expand their vision a little bit and not always look at, oh, well, crowns or something more aggressive, more expensive. They may need that eventually, but what a wonderful alternative.
Yeah, thank you, yes. All right, any other questions? Yeah, Dr. Segura.
Not really a question, but just, I really like what Mark just said about using these not as long-term provisionals, but I'm an advocate of doing the most conservative thing initially, because if you do, you can always do crowns later, you can always do veneers later, but if you do those first, you've precluded yourself from doing something much less conservative. Anyway, so I applaud you on that.
Yeah, thank you. Yes.
I'm really fascinated by the pattern of caries. That's a very unusual caries pattern. Small lesions in the posterior, and you dealt with those in the conventional way, and yet on these lower anterior teeth, large lesions. Did you get any sense from the patient of what his habits were or his drug use patterns were?
Yeah, we did, and that's a good question. We actually quizzed him a bit on that because I kind of had the same thought. It's kind of unusual the way it is. He did methamphetamine a lot, and of course during that time his oral hygiene was really poor. And he told me his drink of choice while he was doing that was Mountain Dew. So he was drinking a lot of Mountain Dew, and he said he liked to swish it between his teeth. But why it happened in the anterior, and I mean there was, obviously we did a lot of posterior restorations, but they weren't in the condition that these anteriors were. So the answer to that is I don't know for sure what that pattern was caused by.
No, I don't know either. I wonder if anybody does. But people who are vaping apparently are getting strange lesions on the upper anteriors. Some people who vape directly onto their teeth, it's quite destructive and ignites lesions that are quite unusual in pattern.
Yeah.
I have seen that in a study club that I'm in. So I'm wondering how, I have no idea how one uses meth, but is it smoked? Is it, what's the?
I've seen patterns like this with individuals in recovery who are taking the Suboxone lingual gel sheets. So they're placed under the tongue, but they have sucrose in them, and they take several minutes to dissolve. And so it's just coating the lower anterior teeth with these sublingual Suboxone, the way it's dispensed. So I usually would ask their rehab facility to switch them to a dissolvable tab where they're not using the sublingual thing.
Okay. Yeah, that's
And
good
they
to
used
know.
to be really popular, like, it was like a breath mint thing. I don't know if you guys remember those, but.
You're a man after my own heart. I've done many cases like that, and I just want to comment that your years in teaching dental anatomy came in handy, didn't it?
Indeed.
I suspect that it made you better at it, teaching dental anatomy, because you knew what the teeth were supposed to look like, and you could actually sculpture them and create them right there in the mouth directly. And I think great case, very, very impressive.
Okay. Thank you. That's kind coming from the master. Dr. Janis is excellent at these kind of things. Any other questions? Yeah.
Okay. All right. Well, thank you,
Okay.
Dr. Dickson. We really appreciate your presentation today.
Yeah.